This conference will now be recorded.
So good evening and welcome to AnCan's virtual chat support group for low and intermediate risk prostate cancer for Monday, September 22nd. Special welcome to our first time visitors as well as hello to our regular participants. I'm your moderator, Stuart Jordan, and I'll be assisted this evening by Bill Franklin, Boykin Jordan, and AnCan's founder, Rick Davis. At AnCan, we have multiple prostate cancer groups for our attendees. In addition to tonight's group for low and intermediate, we have groups that focus on active surveillance, high risk, recurrent, and advanced prostate cancer, and have special groups for men under 60, veterans, and we have a new group starting next month for gay and bi men. Tonight's group addresses low and intermediate risk for those that are planning for or have had treatment, but we do not address recurrence in this group, and we encourage instead to go to visit our high risk recurrent and advanced prostate group. We would also like to note that this is a peer-to-peer support group and should not be taken as medical advice. We're here to share our collective experience and answer questions, and we encourage you to discuss items that you hear here with your doctors. Before we begin, we would like to thank our sponsors for all of our support groups. They are Bayer, Novartis, Johnson & Johnson, Myriad Genetics, Telix, Blue Earth Diagnostics, Foundation Medicine. And we also thank you for supporting us, and you can visit our website, www.ancan.org. And for the new guys, we also encourage you, if you have not already, either to sign up or give us your email addresses so that we can get you on the reminder lists so that you hear about future meetings, be reminded about future meetings when they come up. So with that, the way we work is we welcome our new guys first, and we'll chat with them. And then after we're through with those, we go to the rest of the group for anybody who has any questions or needs any time. So with that, Steve, you're first, so we're going to start there. And I guess we know you live in Portland. I guess, how old are you?
I'm 60.
60. Okay. Are you a veteran?
No, I'm not.
Okay. And how did you hear about AnCan?
So again, I just got my official diagnosis last Wednesday. My partner, Jennifer, has had some health issues of her own, and she used to be a copywriter that did work in healthcare. So she's been very actively researching, and she came across this resource.
Okay. Steve, I don't think we have your email address. So if you want to put it in the chat address to either Bill or myself, we can make sure you get on the list so that we send you reminders. And
sure, yeah, I'll do that. Mm-hmm.
Sure, but let's start talking about what brings you here. When were you diagnosed?
Well, I just got the biopsy results this past Wednesday.
Okay. How did you get to the biopsy? What was the what got you to that step?
Well, so I get an annual physical. The last like 2 and 3 years ago, the PSA number was 4 point something. This past year, it jumped to 6 something, and so that kind of spurred the next step, the biopsy.
Okay. Did you have an MRI before you had your biopsy?
No, I didn't. Yeah, I talked to one other guy who's gone through this, and yeah, he mentioned that that was the next step for him as well. But yeah, for whatever reason, I went straight to the biopsy.
Okay. MRI is pretty much should be part of your standard of care, because what the MRI does is it figures out potentially where the cancer is to guide the biopsy.
Hmm.
And without that, the doctor is just sort of poking you blind, and it's just sort of pin the tail on the donkey. So whatever you tell us this evening as far as what your report says, we're going to have to be a little bit concerned about what they weren't looking for, what they didn't see, and what they didn't find. Um,
Well,
so,
yeah, I mean, I obviously I wasn't directing the care, but you know, they did take, and maybe they always do when they do a biopsy. They took 12 samples, I guess, to get a good range of the prostate. Uh, and the next step they've well, I've scheduled is a PET scan, which as I understand, will help to see if that cancer is spread anywhere. I
yeah,
don't know if that's kind of
okay,
partially what that
yeah,
MRI
yeah.
would do. Mhm.
Well, different thing, different tests. So let's take a step back. We may want to talk about, when you talk to your doctor, you may want to ask why they didn't do an MRI. But let's let's go ahead and tell us about the biopsy. Uh, was it done at doctor's office, or and I guess the question is, was it transrectal or transperineal? What
Uh,
in basic terms, was it up the butt,
yeah,
or okay?
I guess it'd
So
be yeah transrectal. Yeah, uh, not a pleasant experience, but I understand it's sometimes done under a general anesthetic. For me, it wasn't, and though unpleasant, it wasn't. You know, too terrible, I guess.
okay,
Uh, for me, 3 of the 12 samples were cancerous.
okay,
Uh,
that's where we're gonna
okay.
go next. Is so they took 12, and 3 of the 12 were positive. Tell us what they said, what you have about those 3. Do you have a
Yeah,
Gleason score?
I do. Yeah. So uh, in the left base, uh, one of the 2 cores was positive. Uh, the Gleason score says 3 plus 3 equals 6, grade group
Okay,
1.
okay. What's the
Uh,
next one?
the other one is left mid. Uh, that Gleason score is, and that was 2 out of 2 cores were positive, and the Gleason score is 4 plus 3 equals 7. So I think the doctor said that that uh, made it. I can't remember the term. Kind of a funny term given the circumstances. But anyway, it made it so that it was something that required treatment as opposed to something that maybe could be watched.
Okay. Uh, what's really important now is going to be getting a confirmation of the diagnosis. And what we recommend for everybody who has a biopsy is you get a second opinion from a second source uh, on your biopsy, because the different if in fact it's really 4 plus 3, that would lead you in one direction as far as dealing with treatment. If it's 3 plus 4, which it could be a significant portion of biopsies get reread and the grading changes,
Hmm.
that could step you down to a point where the type of treatment that you had decision would be different. And we've got in the chat uh, for you the names of two highly respected experts at doing second opinions, which we probably would want to do. But I'm really uncomfortable with the fact that you haven't had an MRI and we don't know what might else be lurking in there that could be significant, that would totally change what should happen next.
Hmm.
Uh,
Yeah, uh, I was a little lightheaded when talking to the doctor initially there. I don't remember any mention of MRI. It was just this upcoming PET scan, PSMA scan, I think.
okay, the
Uh,
PSMA PET scan looks for spread outside the prostate, which may or may not be where you should be going next. There's no rush uh, to be rushing in to do that.
hmm,
What your focus should be is on getting a confirmation of your basic diagnosis to make sure that we really know what you're dealing with
I,
before you go ahead.
I'm sorry. Yeah, just a question about that. So, uh, getting that second opinion, is that just someone else reading the results of this biopsy, or does it entail a second biopsy?
No, initially it would be it initially it would be your slides from this biopsy would get sent to one of these doctors and they review them and make their own interpretation of the slides.
Oh,
Which now I'll be honest with you, if your MRI, if you did an MRI and it shows something, you may possibly have to consider doing another biopsy at some point after your prostate recovers, which wouldn't be tomorrow. You'd have to wait. No doctor's going to basically rush back in. And quite frankly, if in fact we find out that there's something there, we're going to recommend that you probably find a different doctor to do that second um, biopsy, because frankly, you haven't been getting quality care. Uh,
hmm,
what happens with with the reason that you do an MRI is it's about 85+% accurate in terms of identifying significant cancerous lesions in the prostate. And once they have that, they have a map that they then use to do the biopsy, where the doctor is looking at, he has the MRI, they overlay in real time ultrasound, and they're targeting exactly where they're going because they know in that case where the suspected lesions are. And so they don't have to just randomly poke, they're going for where the areas of concern are. And that's unfortunately is the part of what you've missed.
well,
And
yeah, I'm sorry. There might be a little bit of a delay. I apologize if I'm cutting you off there. Uh, you mentioned just randomly poking. I mean, it seems like they're, uh, systematically gathering samples from the full range of the prostate. Uh, but I take your point that the MRI probably should have been done prior to better guide that
okay,
sampling.
I
Steve,
guy, So, Bill, I don't remember the numbers. Maybe you do, as to what percent of the prostate gets
Uh,
tested when
So,
they do a 12 core.
yeah, Steve, like you said, it's so they use the ultrasound to develop a grid of the prostate, and they take 12 cores from 12 areas. That would be a grid of the prostate, and they hit the different sections that are outlined in your biopsy report. But as Stuart stated, the MRI is going to give you a much better position of where there is a possible tumor. They're going to hit those specific spots, and they could take less samples. That's better for
Mhm.
you as the patient. There's less chance of infection, and it's it's less to put up with if they use the MRI. Any urologist is doing a blind biopsy, and this is our opinion at AnCan, right? If they're just doing, we call them blind biopsies, but it's what I just described.
Uh,
Any urologist is doing that now in this day and age. They're just not getting on they're not getting on the best quality, the standard of care. You should always have an MRI and then get the biopsy after that. And anybody who comes to us who hasn't had a biopsy, that's exactly what we recommend.
Yeah.
And the
Let
other,
me add something to that, Steve. Um, the American Urology Association is just redoing its guidelines for local disease and intermediate disease. And those guidelines state that the draft that they put out, which we reviewed, state the urological oncologist may do a an MRI, and we responded and said the may should be must, because if you speak to any center of excellence that's not a community practice, but somewhere like OHSU, for example, they will not proceed without having done an MRI first.
Hmm.
And the reason for that is because they're taking 12 cores from each section, and they're using the ultrasound to see where the best place might be to take a core. But an MRI is much more accurate, and you don't necessarily need to poke a lot of places. So now what we find is the urologist may take 12 cores, but they're taking 4 or 5 from one particular area where they see the significant that they see something that leads them to believe there may be a mass in that area. And where there is no action, they're not going in there.
Mhm.
And so the MRI becomes vitally important. Now, as Bill said, any urologist who is just doing 12 random cores based on his based on the ultrasound is doing what we call today a blind schematic um, biopsy, and that's just not good enough. He may be right, but he may have missed something, and then you're not going to make the best decision. So we, on many occasions, have said to guys, get rid of this guy right away. Don't even go back to him, and go find yourself a urologist who's up with the times. Because it's hard for
Well,
us to navigate you when your guy is living in the in the Stone Age.
uh, I mean, obviously, this is surprising and kind of not disheartening, but not good news to hear that the doctor I was kind of trusting may not be who I should be trusting. Given that the MRI hasn't
Let's
been
just
done.
see.
Mhm.
Hold your thoughts a minute. Let's just see what
Sure.
David has to say. Go ahead, David.
well, Steve, a year ago, almost exactly, I was in the same position as you. My primary care physician also sent me to a urologist at Oregon Clinic, not the one you saw, but a colleague. and I had to wait a month to get in to see him.
Yeah.
And at the time, I thought, oh gosh, a whole month. But it actually turned out to be a good thing because I used that month to, well, get up to speed on prostate cancer as much as I could in a month, not knowing anything about it. I did have one advantage, kind of like your partner Jennifer, in that I'm a retired medical journalist, so I knew how to get my hands on medical information pretty quickly. And very quickly, I realized exactly what Stuart and Rick are saying is true. The the MRI needs to come before the biopsy, and I'm really a strong proponent that the biopsy needs to be transperineal, not transrectal, because why even, there's like a 3% risk of sepsis with transrectal. Why even mess with that when you can just do a transperineal and eliminate that risk altogether? So knowing that, I then went in to see the urologist at the Oregon Clinic, and lo and behold, he told me exactly what your urologist told you. He said, "Well, I got a spot in my schedule next Thursday. How about we do it then?" And I said, "It's gonna be transperineal, but don't I need an MRI first?" And he said, "No, you don't need an MRI first, and it's going to be transrectal." And, when you're in the doctor's office, things are coming at you fast and furious. Like you said, you're kind of lightheaded and all that. So I was like, that doesn't sit right with me. So I went home, thought about it, and I got on the portal and contacted him and said, listen, I've thought about it. I definitely want a transperineal biopsy, and I want first to have the MRI so we can see what's going on in there. Will you do it that way? And he said no, just point blank, no. So I fired him and I got another one locally who would do it the way I'm describing. If you want a suggestion for another urologist that's, that you might want to engage the services, because I would just consider strongly switching urologists, given the fact that, like my urologist, yours has kind of set in his ways and doing it, in my opinion, in a non-standard of care manner at this point. So that's, and I too have a 4+3. So that's where I'm coming from on that. So if you want to get in touch with me, just, offline at some point, I have scoured the city and scoured the West looking for the best doctors and know a few and can make some suggestions for you if you want.
Okay, yeah, I appreciate that. Yeah, I mean, I'd never heard of the transperineal. Obviously, didn't know about the MRI. And my between my high PSA reading and when I was able to get the biopsy was more like 4 months, I believe, or it was at least 3 months. It was quite a ways out.
Really? Okay. Well, mine probably just had a vacancy in a schedule that next week. That's probably why he wanted to do it that quickly. But uh, yeah, I would say it's time to consider another urologist. And it's unfortunate because, you're going to an expert and you think, okay, they must know the right way to do it. They went to medical school. I didn't go to medical school. Who am I to tell them how to do it? But really, in a lot of cases, you got to tell them how you want it done because they won't necessarily do it the way it really should be done.
I mean, it is interesting that both these doctors at Oregon Clinic, I mean, they must be doing it the way they're doing it for some reason. I mean, do you suppose that's just convenience or just old, what they were taught years ago, not keeping up?
So,
Or,
so
Well,
let me jump in on that
my
one, Steve.
urologist is not that old. He was, I'd
Yeah.
say, about 44 years old. So he's, it's not like he was going to med school back in the 50s. I'm not going to hazard a guess why they're still doing it that way, but it's not acceptable to me.
Okay.
So, Steve, you're not
And,
alone.
and by the way, the urologist I ended up with is not at the Oregon clinic.
Okay.
Yeah, so Steve, you're not alone in this, and so just a couple quick things I want to kind of point out is for both you and David, don't forget to exchange your contact information. You can do it there in chat. And then Steve, what was your PSA? I don't think I caught that.
I can find it right quick. It was 6 something, which was a jump from the 4 something the previous 2 years. But yeah, I actually can look that up pretty quickly here.
Okay, thank you.
I guess that's not. I obviously can go quite a bit higher, but I guess it warranted the next step, which I guess should have been the MRI.
That part was done right. The fact that a 6 is high enough, and the fact that it had gone from 4 to 6, there are other reasons why I could do it, but that's a warning light, and something should have been considered. Unfortunately, that's sort of where it may have gone on the wrong direction. Important thing for you, I know you've just been hit with a diagnosis, you've got cancer, and so there's a lot of stuff, I imagine, we've all been there floating around. The most important thing you need to know is there's absolutely no rush. And if you need to start over with a new doc, you're not taking any risk at all in terms of your health. That unlike cancers that if I diagnose it on Tuesday, they have to operate on Friday. We're at the total other end of the spectrum here. And it grows very, very slowly. And you're not risking anything. And so it's really, you have the opportunity to really feel like you're getting the appropriate care and dealing with the right people, because if you need to be treated, this is, a big decision that,
Sure.
will impact you for, the rest of your life. So you really want to make sure you've got the right doctor. Dave?
Yeah, and also I will reemphasize the fact that please use that information we put in the chat window. Get a second opinion on your biopsy slides. Dr. Zoe and Dr. Epstein are 2 of the preeminent prostate cancer pathologists in the country.
Okay.
Dr. Epstein is actually doing a webinar for us on the 30th of this month, which you may be interested in it, but you've already had one, so it'll give you good information if you want to be on it. But
Yeah.
that'll be
Mhm.
the reminders. But yeah, get that second opinion. I would say before you do the PSMA test. I mean, PSMA PET scan, while not an invasive procedure, if you got a different reading from Dr. Zoe or Dr. Epstein, they might not think it's necessary, but it's still a good diagnostic tool. But I would get the second opinion before that. And as Stuart said, everyone here knows your sense of urgency. Everyone here understands exactly what you're going through. We all went through it. So we can tell you to slow down, take your time. You don't feel like you want to, but if I knew then what I knew now, I would have done some things differently based on what I've learned at AnCan. And I hope we can help you take your time and get the best care that you can. So.
Okay. That's one thing that the doctor mentioned is that there wasn't a big rush. My father had prostate cancer and went through radiation treatment. He was, I think, like 82 or 3. He's 86 now, and unfortunately dying of pancreatic cancer. So that's I'm trying to focus on that somewhat while just trying to get up to speed on my own prostate cancer stuff.
Yeah, so
I-
keep Go ahead. I'm sorry.
Oh, I'm sorry. I was just going to let you know, I did find the PSA numbers. It was 4.8 the end of 2022, 4.7 the end of 2024, and then it jumped to 6.4 in May of the 25.
Yeah. So
I'm sorry, you're going to say something else, sir, Bill?
yeah, I was going to say you'd probably be well served getting one of the genetic tests to see if you have a genetic predisposition to prostate cancer. That can also help you make decisions in your care. And we do have a pancreatic cancer support group here at
Okay.
AnCan. So um, so yeah, get that second opinion. Come back to us. We'll be happy to guide you for as long as we are here and you are here. So
Okay. Well, I appreciate all this advice and help even so far. Yep.
David, did you
David,
want to say something else?
Yeah, just as we're sort of saying regarding the biopsy, look before you leap, and you can't necessarily take urologists at face value. It's not just true regarding the biopsy, it's also true regarding the treatment. For example, I mentioned a little while ago, I switched urologists after the first one wanted to skip the MRI. Well, my second one did a great job with the biopsy. He did the MR, we went with the MRI first, did the transperineal. It went very smoothly. I couldn't have been happier with him. But when it came time to have the post biopsy meeting, he first showed me my Sloan Kettering nomogram, which said with a 4+3, my chances, well, no, actually, first he said, okay, you got a 4+3. I think you need surgery. And I said, oh, really? Because I was thinking about radiation instead of surgery. And he pulls out the Sloan Kettering nomogram with my numbers on it. And according to that nomogram, I had about a 50% chance of a recurrence with surgery within the first 5 years. Well, that didn't sound so good to me. And yet he still pursued the notion of surgery. You've also got to, the expression trust but verify. I think I went into this whole process with the motto of distrust and verify because I just had bad advice from my first doctor, dubious advice from my second doctor, and really went into every step beyond that with kind of a skeptical mindset. There are great doctors out there. There are great treatments out there. There are great ways of doing this whole thing, but you can't just expect great things from the urologist, in your neighborhood. It sometimes requires traveling or sleuthing out a really good doctor in your own hometown.
Steve, Rick just posted in the chat. There's the Promise study, which is an opportunity for free to get a genetic test done that will identify if there are any mutations. You want to grab that link out of the chat. One easy way to do it is just click on it and it will open, and then you have it there for later. And if you're going to do that, you need to do it quickly because that study is just about to close. But there's an opportunity. They will send you a little vial that you spit or swab in, and then they check it, and then they give you a report back as to whether they identify any mutations and then provide more information after that. It's a great, quick way to cover one of the other bases that you're going to want to know as you go forward. Does
Okay.
anybody else in the group have any comments or that you want to share with Steve? Dave, why don't we do you, and then we've got to move on to Kevin.
Yeah, regarding the PROMISE study, I did that. And in your case, Steve, the fact that your dad had prostate cancer and pancreatic cancer, it's a little bit of a red flag. Do you have other members of your family that have had different kinds of cancer, including the women?
Uh, well, my maternal grandmother had cancer, but I believe it was associated with her smoking.
Okay.
I can't think of anyone else. Yeah.
I also would second the notion of doing that promise study. I did it. My father, like yours, had prostate cancer. I have had a lot of breast cancer in my family among the female relatives, and I wasn't really expecting any sort of a positive result from that test, but I got one. I turned out I had BRCA1. And I mention that only because among the risk factors is pancreatic cancer.
Uh,
So not to the degree of BRCA2, but nonetheless, it's associated with it, and as well as male breast cancer. So it's worth doing, and the test is free. You just spit in a tube. I'd recommend doing that.
oh yeah. I'm joining you tonight on my phone, so can't look at the chat simultaneously. But I did look over and I appreciate all the links and so forth. Yeah, I'll definitely follow up on that genetic test.
Yeah,
Okay, well,
Steve,
Steve,
if there's anything you don't capture out of the chat, my email address is in there, but it's bfranklin@ancan.org, and I'll be happy to provide the information to you.
Okay. Yeah. Thank you very much.
All right, Kevin is up next, you
good.
said, Stuart?
Yep. Kevin, thank you, Steve.
Thank
Kevin,
you.
hi.
So
How are you? How are you?
good. How are you?
Good, thank you. Uh, Kevin, where do you live?
I live in Sault Ste. Marie, Ontario, which is on the shores of the St. Mary's River that separates Canada and Michigan.
Okay. Uh, how old are you?
I am 64. I am not a
Okay.
veteran.
Okay.
I am a dual citizen, and my prostate cancer journey started in Arkansas, and now I'm
Okay.
here in Sault Ste. Marie, Canada. So I have experience on both sides of the border. And
Okay.
just listening to Steve share his story reminds me of why I came back to this group, because I attended about 5 active surveillance meetings at the end of last year and into January, and received similar advice, which has been extremely helpful in these last 8 months. So let me just kind of share with you, like Rick had attended those active surveillance groups, and I recognize Rick. I was first diagnosed in Arkansas with a PSA level of 7.2. And my primary care physician, who was new to me, uh, had me contact a urologist in Fayetteville, Arkansas, which is where I was living, a young doctor who had me we had an MRI. And then he called me back into his office and he said, based on the MRI, I'd like to do the biopsy. And I'd like to, we have two options. We could do rectal or we could do transperineal. And my wife happens to be in the healthcare field. And she's there, well, if the risk for infection is almost reduced to zero with the transperineal, go that way. So we did. And he took 17 samples on that biopsy. And I had 4 that were 3+3, and I had 1 that was a 3+4. And the 3+4, it states that it involved 1 core of, and 40% of the biopsy tissue. 5% was this pattern 4 of that 3+4. So then I came to Canada because my mother-in-law needed us back, and I had to find a urologist, and I had to kind of figure out what I was going to do here. And the urologist in this community gave me two options. He said, why don't you look at radiation and why don't you look at surgery? He was going to be the surgeon, and he only does open prostatectomies. And I went to the radiologist, and my prostate is huge. It's about 160 cc's. So it's like 4 times the size, I guess, of a normal prostate. And radiation, after looking at it and doing some research, I was just scared that I was going to have this mass in my body that had been treated, and then I would have drainage issues later on that would result in maybe a rotor-rooter procedure, or radiation didn't seem to be an option to me. So my urologist here in the Sioux said, I can operate and take that prostate out in 2 weeks. And I went, based on the fact that I attended these AnCan meetings, I went, oh, wait, whoa, let me get to a center of excellence. So 8 hours from here in Toronto, Princess Margaret Cancer Center, I went down there with the kind of the objective of talking about having my prostate removed robotically. And Dr. Finelli, well known in Canada, really good surgeon, he looked at my results. I had a couple other PSAs. So the first one was 7.2, then it was 7.2, then it was 6.2, then it was 8. And he said, nah, I don't know about removal. Why don't we put you in contact with a doctor here who's looking at a clinical trial with focal therapy? But in order to get you into that clinical trial, we're going to have to do another MRI, which will involve another trip to Toronto, and we're going to have to do another biopsy. So I went back, that was February. Then in April, I went back for an MRI. Oh, and I didn't add that because of these meetings, I got a second opinion from Johns Hopkins on that very first Arkansas biopsy, and it confirmed the 3.3s and the 1.34. So I went down there, I had the MRI, got the MRI results back, and last Monday, a week ago, I had another transperineal under sedation, and the first one was under sedation too. And I don't know how you could go through that with your legs up in the stirrups and everything, not sedated. But anyway, they went in there and he took 22 samples. And he explained it to me before he put me under. He said, Kevin, we're going after this one area, but we want to make sure there's this one other area that we're just kind of suspect. We don't think anything's there, but we're going to go there. And so he took these 22 samples, and I was discharged same day, of course. And now I'm just waiting those results. So that sequencing that was talked about in the first, 40 minutes, I was fortunate in Arkansas because that's the way that young urologist kind of saw it. And he wasn't going to do anything to me. He told me, you got 2 years, Kevin. We'll do another MRI down the road. We'll do another biopsy down the road. You don't need to do anything. But when I moved here, my doctor, urologist here, showed me a chart and said, based on your age, Kevin, you got to do something or you're going to be dead like in, I think it was 15 years. And so he kind of really had me thinking, okay, radiation or remove my prostate. And then during one of these AnCan meetings in the active surveillance group, somebody was considering focal therapy. And they said, look, we don't talk therapy in active surveillance. So if that's the direction that you're going, then perhaps you need to go low intermediate group. And it was maybe 2 weeks before my recent biopsy, I watched a YouTube video of one of these recent meetings and I went, I got to get back to these meetings because of what's shared here. All of you guys, we're all going through the same thing and we're faced with the same fear, anxiety, and lack of knowledge. But the more that you get educated, the more you understand, the more you can make decisions. So it's been extremely helpful. And that's where I'm at right now, just waiting on that second biopsy.
Okay. You haven't told us anything other than the fact that the doctor told you you needed to do something that identifies the need to stop doing surveillance and be treated.
Right.
And so we really need to hear what the biopsy results come back to see if they found anything else.
Okay.
You're going to want to get I think, that with being in Toronto, you're at a really good place in terms of getting appropriate quality of care, but you're still going to want a second opinion depending, on whatever these results are.
Okay.
And you're at a place where I was a year ago, which is, do I watch or do I treat? And once you get some more information, then you can really address that. Because if in fact your first biopsy is accurate and you have one small bit of 3+4, there is pretty good reason not to treat and just to watch it. Now, if it turns out that there's something more there, or it gets to the point where you do want to talk about focal, I'm somebody who can talk to you about focal.
Excellent.
I've had focal. I've researched the heck out of it, and I know the good and I know the bad, and it's something, but we're not there yet. You're not there
Okay.
yet. When these results will tell you something as to whether or not they saw something. Just out of curiosity, what did the MRI say in terms of? Do you know what your PIRAD score was?
Yep. Yep. Let me just click to it, and I'll log back on. Give me a second.
Yes.
Can you hear me when I go to
Yep.
okay. So let me go to that, and the MRI. So, it confirmed the size of the prostate. It confirmed the PSA density being only 0.04. So there's a lesion, PRADS 4, assessment category a T24, DWI 4, and a DCE positive. And the size is 7 millimeters by 4 millimeters in the left posteromedial mid-gland peripheral zone with an SC of 4 and a LM of 16. And there's the prostate margin, there was no involvement. And that's another thing that was confirmed here in the SUE is that everything is still contained in the prostate. They did like a bone scan and kind of confirmed that. And the MRI kind of confirms that. And there's been no migration yet. So it's that one area there. And then it also says things like lymph nodes, no pelvic lymphopathy, bones, no suspicious pelvic bone lesions, a tuberculated urinary bladder. And then the impression is the PRADS 4 lesion, left postural medial, mid-gland peripheral zone, suspicious for focus of clinically significant prostate cancer. Highest assessment category is 4.
Okay.
Right.
Rick,
So the highest assessment category is 4, but you're still a 3+4, and there's only 5% 4, as Stuart correctly pointed out, Kevin.
Yeah.
Now,
and that's what John Hopkins confirmed.
Did the doctor tell you that in fact with 160 cc prostate, your PSA is very low?
Missed that last part after the 160 cc's, Rick.
Did he tell you that with a prostate of 160 cc's, which is a very large prostate, 160?
Yeah.
Did he tell you that your PSA was very low?
Yes, and he said like the density, the PSA density, which is another measure of 0.04. It was almost like you don't have
so
cancer.
let me got it. I got it. Let me continue. I don't know where the leap in faith goes from. You got a low prostate with almost no 4, and you're going to die in 15 years. I don't know where he gets that. I don't know where he gets that from. And,
It was like a little chart.
And what's more, I'd like to see you publish that chart. I'd like to see how it fits in with you. I'd like to know if that chart was published by the Canadian Surgeons Association, because it's rubbish. And it makes us crazy when we hear that crap.
Yeah, I'll try and get the reference, Rick, of what
Yeah,
that
I
chart
mean,
was. Yeah.
do get a reference, and I'll eat my hat if we can validate that. It is absolute rubbish. Now, what I would say is go get a second opinion from somebody like Larry Klotz, because Larry Klotz strongly favors active surveillance.
Yeah, he's at Sunnybrook, right?
He's at Sunnybrook, and Sunnybrook has its own its own cohort
Right.
of active surveillance men that they follow. And you are, I would think, a perfect candidate with such a large prostate. Maybe you need some treatment for that, but with such a large prostate to go in and mess around with 5% 4 and only 3 cause positive, it's crazy. And that's what I would say. Get your ass over to somebody who supports. The other problem I have is, yeah, they love to do the centers of excellence love to do focal because they're trying to make a name for themselves on what's important with focal, including Sunnybrook, especially Sunnybrook,
With that
because
Tesla,
of
right?
clots.
Mhm.
But as Stuart will tell you as we go down the road in this, we're not huge fans of focal because the recurrence rate is exceptionally high.
Ah,
And what we are big fans of is not treating when you don't need to treat. And what I'm thinking is no harm done in all of this that you've done, but you really need to get a decent, solid second opinion whether you're a good candidate for active surveillance. And on paper, we can't give you the medical advice, but it sure looks like it unless something else comes up. So,
okay. Okay. Thanks, Rick.
Bill, Bill in Virginia.
Kevin, I have a very similar profile to you, 3+4. My 4 is 10%. My biopsy was read by Dr. Epstein, and I was told, I would concur with Rick's questioning that chart. I was told it was 75 to 80% out through 15 years of survival. It's not, that seems dire.
Right. Okay. And it sounded dire. I mean, I haven't seen them pretty much since because I've been exploring this center of excellence path.
Kevin, are they doing any genetic test? Are they doing a Decipher test or a Polaris off of this most recent biopsy? Or did you have one on the first one?
I did not have one on the first one. I remember we talked about this at AnCan meetings I've attended in the past, and I'll have to explore that, the genetic testing. My father doesn't have cancer, still alive, 87, got other issues, but my sister had breast cancer, so
Okay,
uh,
there are two types of genetic testing. There's the test that looks at the genes that you were born with, that looks for mutations. And there's a Decipher or Polaris test that measures, that specifically looks at the genes of
yeah.
the cancer.
Stuart, can I just stop you? The
Yep.
availability in Canada is not like it is here. It's not so
Okay.
easy just to get a Decipher test. We're not saying it's a bad test, but we need to recognize that it's much, much harder. Think of Joe Mingrone. It's very hard to get those tests unless you come back over the border and you get them ordered by a U.S. Urologist. There's a logistical problem for our Canadian friends.
okay.
Okay. Kev, did you have any other questions?
No other questions. It's just really good to be back.
Good.
Oh,
We're
I would
happy to
say
have you here. You
Yeah.
know, you know, I wouldn't be rushing to try and figure, and towards any sort of treatment unless something significant more shows up, because the out fact is any treatment will have side effects, and they're side effects that you will live with for the rest of your life. And anybody who tells you otherwise is not telling you the truth. So if you need treatment, we want to help guide you to what could be the right treatment. But by the same token, if you don't need it or it can be put off, you should, we really want to help you answer that question first.
Okay. Great.
Yeah, I'll second that, Kevin. I say you're doing everything. Sounds like you're doing everything right. Take your time, get the most information you can, and as Rick said, I mean, active surveillance may be the way to go. Come back after you get these new biopsy results and see what we got.
Absolutely. I'll share them with you.
Anybody else in the group have anything for Kevin? Okay. Tom and Robin, you guys came in late. Do you have questions for the group? We can't hear you. I can
We
see
still
you
we,
on.
sh- we still have
Go
to get
ahead.
to Jim, but Tom and Robin, if you're unmuted, we cannot hear you. So you might want to see if you've got the right microphone selected. Or
Okay, well, we can come back. To you guys. Just speak up or raise your hand if figure out what's going on technical wise. Uh, did Who else would like some time? Jim, did you need some?
Jim Stewart said he was new.
No, Jim's not new.
Jim wasn't new? Oh, my bad. If Jim's not
I,
new.
I'm not. I'm very old, actually, in a lot of different ways. So
I
definitely
thought
not
we
new.
had another new. I thought I wrote down 3 new guys.
I had, I
You
had
I had
you
someone,
named,
did. The
I had
third
someone
one
named
was
Dan on
Dan.
here.
and he
You
Yeah,
left.
you you did, Bill. The third
it
one
was
was
Dan.
Dan, and Dan belongs in the group tomorrow.
Oh, okay. Yeah. All right.
And
Sorry,
David
And
guys.
Don,
wanted some
It's been a long
time.
day.
Dave in Portland wanted some time. David in Portland.
No, I'm good. I just had
Yeah.
just
Okay.
not really treatment related questions. I'm good.
Tom and Robin, any luck there? Shoot us a message if you're hearing us. Donald, did you have anything you wanted to bring up with the group? You're muted. Tom and Robin, you might want to.
Okay, you can hear me now, right?
Yes.
Yeah, I'm all Donald's all set. I'm sorry.
Okay, no, that's fine. Tom and Robin, you guys, if you want to try logging out and logging back in, we'll stretch on this end to give you the time to try and do that. Uh,
Yeah, Tom and Robin, go up. I know you can hear us because we can see you flipping your microphone on and off. You need to go up to the settings, which are at the top right, and make sure you've selected the correct microphone. Failing that, scroll up to the very top of the chat, and there should be a telephone number pinned up there, which is the technical support for GoToMeeting. Because as I recall, we had this problem last week with you when you came or last time when you came into the meeting and we couldn't hear you. So there's something going on where GoToMeeting isn't recognizing your microphone. And that might be beyond our technical fix-it capabilities here. So that would be my suggestion. Make sure you got the right microphone, number one. Number two, go out and come back. If it doesn't make a difference, go to dial that number and have them do a tech check with them and find out why we can't hear you. And you can always put something in the chat window too.
Boykin just posted the phone-in number if you want to try that.
Oh yeah, you can phone in. Good thinking, Colonel.
Yeah, you could
Okay.
leave your computer connected, mute your microphone on your computer, and then call in on the telephone, and we could talk to you.
Yeah, that's a very good suggestion.
See, that's why he's a retired colonel.
That's right. He's the only one of us who can think straight. Oh,
I had to do I-4 traffic tonight, so I'm claiming that I'm mentally burnt out. So
okay. Well, whilst we're waiting for Tom and Robin to connect through the phone, let us just give you a little bit of a plug for Epstein, who is in the chat, and the registration is in the chat. And for those who are going to listen to this later, the registration will be in your notes, the quick registration. So Dr. Epstein is the premier genitourinary pathologist in the world. I don't think anybody would argue with that. And he's been an advisory board member for us at AnCan for 3 or 4 years now. He left Johns Hopkins. He took a couple of years sabbatical. He's now back. He wants to tell us about where he is. And I would have to say that this webinar will be very interesting, because he's going to pitch his services. He's going to tell you all about crib reform and everything else. And it would be an hour and a half well spent. Stuart's going to be monitoring the questions for us, and along with a couple of other people. And by the way, Tom and Robin, we cannot hear you, and we don't see you registered in this group. So I think that you may not have come into the right group. 222-583-973. And you're not in this group at this point in time. You're not in this room at this point in time. Try again. 646-749-3129, and then just put in 222-583-973 and pound. So yes, I encourage everybody to attend, and tell your friends. It'll be a very useful, helpful event.
One of the things about Dr. Epstein that may, and actually Dr. Ming Xiao also, is they're very happy to get on the phone and talk to you. So, for Steve, Kevin, when it's not just you send this thing off into the void and you get a piece of paper back. They're both very happy to get on the phone and explain to you what they see and what they think, which also is part of what makes them exceptional. Okay, Tom and Robin say we can hear you. Can you say something?
Yes, can you hear us?
Yes, we can. Hey.
Yay, that worked.
So
Hey.
what can we do for you?
So obviously this is Robin, and my husband Tom, he stepped into the other room, but it kind of started. He had a little mass in his scrotum area, small, and we went to a local urologist who did I want to say a sonogram, but that may not be the right term. But he did that procedure and asked us, when the last time we had a PSA test was, and it had been some time. And this was in April of this year. And so he did the PSA test. Tom came back at 5.93, which he said wasn't real elevated. But my husband has a rare cancer, and because of his background with that doctor decided to go ahead and order an MRI. And we live in El Paso, Texas, and so we do a lot of our stuff over at Mayo in Scottsdale. So we took the MRI request or orders over to Mayo, and Tom had an MRI done there. And at the same time, they went ahead and retested his PSA, and this was in early August of this year. And the MRI came back as they really weren't seeing anything. It just said he had BPH. They didn't see any lesions. I did notice a PIRADS on there of 2. And then the PSA, though, came back at 7.2. And because of the huge jump from April to August, the doctor at Mayo said it was up to us, but maybe we should have a biopsy. And because of Tom's history, just to be on the safe side, we opted to do a transperineal biopsy. That biopsy came back with 2 out of 12 cores showing positive for cancer. So the first core was showing 2%, and it was a 3+3. And then the second core was showing 20% of that core as a 4+3. And they've given us some options like, active surveillance. They didn't think focal therapy would be an option because there's not a lesion. Radiation or remove the prostate. And so we're just, of course, trying to do try to get educated and trying to figure out here what we want to do. We do have a call on Friday with the radiology team at Mayo just to get information. And I have requested the MRI results and the biopsy to go to some of these doctors because we did one of the meetings last week, and some of these doctors you're putting in the chat was shared. And so we're going to go get a second opinion on the biopsy and also on the MRI.
The most important thing is going to be getting a second opinion from either Dr. Epstein or Dr. Ming Xiao on the biopsy.
Okay.
Because you only have 2 positives. The 3+3 is nothing, and that 4+3 needs to be checked by somebody totally separate to see if they concur. Because if they downgrade that, which can happen a lot, you still might be in a situation where you don't need treatment. It's too, you don't know. So rushing ahead in terms of figuring out what type of treatment is really getting ahead of yourself. By all means,
Okay.
Listen and learn as to what they say. The part that we don't know is your husband's other cancers in terms of how that might play into this. But I would start with just slow down. You get that result. You get that second opinion, and let's see what happened and what happens there.
Okay. So even a 4+3 core, if you look at that particular area, they made it sound like that it's more aggressive. And if that does come back accurate, how fast does that grow? I mean, or is it hard to say?
In most instances, a 4+3 grows just as slow as everything else. So there's not a rush.
Okay.
So, if it gets confirmed as a significant 4+3, There will be there will be a conversation as to whether you can watch it or whether it needs to be treated, and then what the appropriate treatment would be. And again, at that point, uh, your husband's other conditions will come into it. How old is your husband?
He's 62.
62. Okay. Uh, is he a
Just a
veteran?
spring chicken.
No.
Okay. Just wanted to double check.
Hmm.
So, there will be time for the discussion as to whether or not it's needed.
Hmm.
What is what's the other cancer?
He has GIST cancer. It's a gastrointestinal stromal tumor.
Yes, we know all about GIST cancer. In
Yes.
fact, what we'll do is send you. Are you signed up with us? Do we have your email?
Yes, I signed up for prostate, but we belong to Life Raft Group as well on his GIST. I don't know if you're familiar with them. We attend meetings with them.
No, I'm sorry. What was the name of that group?
It's called Life Raft.
Life Raft. No. I just want to know if we don't have your email, then you can send it to me at rd@ancan.org. I just wrote about GIST because one of our star volunteers also has GIST. Now, the problem with GIST is that it expresses PSMA. And so that can become very confusing. So with a GIST tumor, you have to be really careful when you do a PSMA scan. In the case of our guy, who for the sake of this call we'll call Richard Stanton, they confused the tumors because he had a mesenchymal lymph node with prostate cancer that was right by the GIST. GIST, folks, is a gastrointestinal stromal tumor. And that's where you get GIST from, GIST, gastrointestinal stromal tumor. And they went to biopsy the GIST, and they got this was 2 or 3 years ago, and they got the node by mistake, and so they just said, oh, you just got continuation of your advanced prostate cancer. And then this year he did a lot more research, finished up going to some centers of excellence, and figured out he had a GIST, which he is actually going to surveil because it's been there since 2011. But yes, as you can hear, we know a little bit about GIST, and your timing's perfect. And send me an email, and we'll make sure that I'll send you this this guy. Now, the question that I have is, what is the length of the core that, what is the length of the tumor that they found in the 4+3? How much cancer was there?
Well, they never said there was a tumor, but they said a 20% in the core.
Okay, well, that's a tumor. But how long was that core? How long was the part of that core that they found that was active, let's say?
Does it tell me in the biopsy results?
It should do. I mean, I haven't seen, I might have done, but I don't recall recently seeing a Mayo report. But if not, if you had a perineal, you probably saw Dan Frendel, right?
Yes, we did.
Okay, so send a note in the portal to Dr. Frendel and say to him, the AnCan guys are asking, because he knows who we are. The AnCan guys are asking, how long was the total? How long was the total tumor in the core? And then you can figure out how much cancer you had. You see where we're going with this is, yeah, 20% for it might be significant, but if the whole thing was 7 millimeters long, 8 millimeters long, we're talking about 2 millimeters of 4. And then we start having to wonder about significance. And then from there, if we get a second opinion and Epstein or Zhao think, oh, it wasn't really a 4 plus 3, it was really a 3 plus 4, then it's another ball game. So just because there's 20% doesn't mean anything unless we know the length. 20% of 0 is 0. You know what I'm saying?
Yes. Yes. Yeah, that makes sense.
So we have to know the length of that core as well as the percentage. It makes me a little crazy when they give you percentages, because all it does is frighten you. You don't know how much cancer's there. So we got to figure out how much cancer is there. Then we got to figure out what's the right treatment for that cancer. Usually 4 plus 3, as we've said before earlier with Steve, I think that was before you got on, who has a similar situation. Yeah, we need to do something with 4 plus 3, but to some extent it does matter how much 4 there is, and that has to get figured in. So that would be my first question. How long was it? And the second thing would be, please send these calls out to Dr. Epstein or Dr. Zhao. I want a second opinion.
Okay. It's telling me, I think I'm on the biopsy deal right now. Trying to see where to.
So the total length of the core is not what you want, because they will give you, Dr. John, correct me if I'm wrong, but they usually give you the total length of the whole core that they took, and then they also give you the length of the amount that was cancerous. Is that right?
Yeah, but if we get the total length, we can multiply it by 20%, I guess.
Well, no, because the total length is the total length of the tissue. So we got 3 things going on here. We got the total.
I see. It's 20% of the cancer, not 20% of the total length. Okay, gotcha.
That's right.
Yep.
So this is what it says. It says in one core involving 20% of the needle core tissue and measuring 2.5 millimeters in length is what it says. That's about all I see. I don't know if that helps.
So it sounds a little skinny for a total length of 2.5 millimeters. But if that was the total length of the core that had cancer, 20% of 2.5 millimeters is 0.5 millimeter. And 0.5 millimeter, you've got to have some real hard discussions to determine whether we need treatment on that right now, because it isn't it's really small.
That's what bothers me about these biopsies. It's like interviewing 5 people on Fifth Avenue and then saying something about the entire population of New York City.
Well, and then how do you know if it's not long enough that they're really reading it right? Like there could be more there if they went deeper. Is that true, or?
Sure.
I mean,
yeah, 90 whatever 8% of the prostate tissue is unbiopsied. That's why we really got to rely on these experts so much to interpret the results.
And maybe to say, send your if that's the case, maybe maybe the MRI needs to get sent to AI to prostate ID to give you an idea of how long is the lesion that they see.
Oh yeah, we do. We were going to send that because they didn't see any lesions on the MRI at all.
Oh,
Well,
Yeah, there was nothing.
well, look, if you go back to Mayo, you're going to go past my house, so you can I'll meet you in Tucson as you're passing through. I'm 40 miles south of you on I-19 as you go through Tucson. But
Gotcha.
maybe with a situation like this, after you get the reread, maybe you need to head in the other direction and get a second opinion in Houston or in Dallas or even in San Antonio.
there is a school of thought that says if the MRI didn't see it, then it's not clinically significant.
That's right.
I don't know if I have confidence in that, but there are a lot of people who believe that.
Stuart, what do you think about that? Because I think that's something you've given some thought to about if it's not on the MRI.
Yeah, no, I think probably more than likely that Mayo did an adequate MRI. The AI might be a helpful little test to make sure that they didn't miss something. But there's there's a very strong school of thought among doctors that these ghost lesions that don't show up on MRIs are really minor events, even if in this case it turns out that there's a tiny, tiny spot of 4+3. So, it's worth investigating. There's no rush to do anything, and trying it. We really want to get some second opinion answers and insight into what they're seeing is to figure out whether you guys need to worry about this.
Okay.
And Robin, please ask Dan Frendel how much 4 is there exactly in terms of length. That's how I would phrase it. Dr. Frendel, how much 4 is there from the biopsy in terms of length? Let's sort of get a confirmation that we're right and we're looking at 0.5 millimeter, because that changes the conversation.
Okay. Now, when we send off the step to get a second opinion on the biopsy, do these doctors actually give you a treatment suggestion? Like, here's how you could, here's some of the choices that you could do with that, or?
So,
no.
Do they do that in the report? No. But the beauty with both these doctors, and the reason Dr. Zhao does it is because he was trained by Dr. Epstein, is that they call you up and you can have a chat with them. And in that chat, you can ask them, and in that chat, they've been known to give an opinion. Stuart, did you get a call from either Zhao or Epstein?
No, I didn't, but that's my second opinion was done at MSK. But my brother talked to Dr. Zhao on the phone after he got his second opinion. And my brother's one where the second opinion changed the read from the biopsy. In his case, it upgraded from 3+3 to 3+4. But what is it? 30+% of these second opinions change the read.
Treatment decisions. Did anybody has anybody else had a chat with either Dr. Zhao or Dr. Epstein who's on the call tonight? We have plenty of people who have, but I don't know if there's anybody on tonight. Oh, Bill's got his hand up. Go ahead, Bill.
Yeah,
Rick, I didn't get a chat. I had an email discussion with him, not a phone chat, but he
Okay.
did change 2 of my scores.
And
Now,
did you ask him about treatment options in the email chat, Bill?
I didn't think about it, to be honest with you.
Okay.
He changed a 3+3 to a 3+4. He changed the 3+4 to a 3+3. He didn't talk about
Robin,
Yes.
sorry, Robin, the one thing, if you go to Dr. Epstein, one of the things that you'd want to talk to him about is also make sure he knows about the gist and whether he thinks that has any impact on everything else here, because he's a guy
Okay.
who would be able to give you an intelligent answer on
Ooh,
that as
Yeah.
well.
yeah, and
It's
you know what? You can, Robin,
Uh,
you can even write to Stuart. Robin, you can write to Stuart at AnCan.org, and he'll send you my gist article because I know he has it in his possession. So that would be even better for me if you wrote to Stuart.
Okay. Okay.
and also, if you have the time, come to the Epstein webinar, and you can hear what he has to say, and probably get pose a question or two to him if you need to. So, any other questions there, Robert?
No, that's very helpful. Thank you so much.
It's a
Okay.
pleasure.
Well,
And my buddy Henry seems like he wants to get a word in. Go ahead, Henry.
Yeah, I had a long chat with Dr. Epstein. He makes himself available if you really want to have that conversation. He's there for you. So, um, very informative and very helpful.
Great. Did you ask him about treatment options, Henry?
Yes, I did. I got a confirmation from him from my radiologist that it was better for me, for my condition, to have surgery. And he somewhat also stated it was better for me in my condition to have surgery.
Thanks. Really helpful.
hey, anybody else, either for Robin or anybody else, have any other questions? No? With that, then I guess we can call it an evening. Don't forget about the Epstein webinar. And Rick, what's our schedule for next month?
Next month, we will be meeting for the first time on the 13th. Monday, the 13th, will be the first meeting of that month. And the second meeting will be on the 27th.
Okay, guys. So Kevin, Steve, you've got plenty of time to do your homework. Come back and see us on the 13th, and we'll hopefully help you at the next step of the way. That, I
Okay,
think
yeah.
we're-
I was just gonna say, yeah, thank you very much.
Okay, well, have a good
Pleasure.
evening.
Make sure you send us your email, Steve, so we can get a reminder to you, and anything else we said we get you. I can't remember
Sure, yeah,
what.
will do.
Okay. All right. If the mods want to hang around for a second, we can have a little chat.